antenatal. Then the period during which labor starts and then delivery of the baby is intrapartum, and then subsequently postnatal. So I'll be taking us through antenatal care. Antenatal care has evolved over time, um, and based on this evolution of the antenatal care, there have been different methods that have been used, and all of them were proposed by the WHO. So I'll be starting today. My talk today is basically going to be on what we use mostly in Nigeria, which is the traditional method of antenatal care. So the objectives of antenatal care is to promote and maintain the physical, mental, and social health of the mother and baby by providing education on nutrition, personal hygiene, and the birthing process, to detect and manage complications during pregnancy, to develop birth preparedness and complication readiness, and to help the mother prepare for breastfeeding, as well as to ensure that the woman has a normal postnatal period or the puerperium. So it is one of the pillars of the safe motherhood, which was propounded sometimes in the 90s, to ensure that a woman has the whole essence of a woman safe has a safe delivery process, safe pregnancy, safe delivery, and safe post-delivery process, as well as a safe reproductive period. So an effective antenatal care is supposed to be a care that is gotten from a skilled attendant and a continuity of the care, preparation for birth and potential complications. It's meant to promote health and prevent diseases. So some of the things that actually should be done in this period included prophylaxis against tetanus, malaria, nutritional supplementation, as well as preventing these women from taking alcohol and tobacco. So, and also some of the other things that will be done, diseases are detected early and treated as appropriate. So the expectations from this brief interaction is that we'll be able to diagnose pregnancy through an understanding of some of the signs and symptoms, and then we should be able to give an accurate date of pregnancy, usually from the last menstrual period, and then we should be able to calculate the expected delivery date, as well as the gestational age at any time a woman comes to us, and then describe the interventions appropriate to the expected physiologic and psychologic changes in pregnancy. So I'll be going straight into, let's start from the diagnosis of pregnancy, which is one of the things, that is needed before antenatal care can start. This can be done usually from the clinical aspect, from the symptoms of early pregnancy and some of the signs, as well as some of the investigations, including an ultrasound scan. So there are presumptive, probable, and then a positive or a confirmatory test for pregnancy. And this includes one of the presumptive tests are the symptoms of this patient, cessation of menstruation, a period where we call it menorrhea, nausea, vomiting, changes in appetite, fatigue, urinary frequency, breast enlargement and tenderness, mood changes, and quickening. These are all cessation of menstruation. Once a woman is not seeing her period, for usually for women that have regular cycles, either between 21 and 35 days, by the time they miss their period for that length of time, they begin to worry. And then some of the signs, which are excessive production of beta HCG, causes nausea and then vomiting. And then because of this, the woman would have some form of anorexia. And then because they are not eating well, a lot of them are prone to have fatigue. And then urinary frequency usually increases. Occasionally, because of the breast development, they have breast enlargement and then tenderness, and then mood changes. Quickening is usually the process by which the woman starts feeling the kicks of the baby or the baby movements. So some of the signs of pregnancy are those signs that we can feel on the vulva, in the vagina, and then even on the uterus itself, including the cervix. So on the vulva, usually the vulva might appear soft and violet, what is called the Jagmeier sign. And then the vagina, which is the Chadwick sign, would appear soft, warm, and dark blue or published red. And then the cervix could be soft and violet, or what is called the Godel sign. So by 6 to 8 weeks, the cervix softens and has the consistency of the lips of the mouth, and is different from the non-pregnant cervix, which is almost always firm. The signs on which of the uterus, especially when the uterus begins to enlarge above about 12 weeks, in this you have the Palmer sign and then the Hager sign. The Palmer sign is the intermittent uterine contraction that is usually felt during when you're trying to do a bimanual examination for this patient. There's usually these contractions of the, especially the fundus of the uterus that is felt, and then the Hager sign, which is usually felt as a firm cervix, that is separate from the, enlarging uterus, because at this point in time the cervix has not yet started really enlarging, and is usually felt as a separate mass from the, enlarging uterus. So some of the signs includes the enlargement of the breast, and then pigmentation of the areola, which never goes back to the initial pigmentation. Appearance of secondary areola, which might look like the third stage of Turner, third stage of breast development, and then prominent Montgomery signs. And then from the third month of pregnancy, some women might begin to see some discharge of milk, which is called colostrum. Then some of the tests that are done, confirmatory tests that are done for patients, would include a urine pregnancy test, which actually detects at least a 50 milliliter international unit of beta HCG. And then this can also be done on the blood using the serum as well. And then one of the most important confirmatory tests is an ultrasound scan where the baby is going to be seen in utero. I'm not going to go through some of the things that cause a false positive pregnancy test. When you get the slide, you can go through that. And then, so as I said, the sure sign of pregnancy is an ultrasound evidence of the pregnancy. And a TVS, that's the transvaginal scan, can actually detect this pregnancy far much earlier than a transabdominal ultrasound scan. As early as the 5th week, the transvaginal scan can detect this pregnancy sac, and then by 6 weeks, it can detect the yolk sac as well as the fetal heartbeats. While a transabdominal scan can only detect usually from 6 to 7 weeks, 6.5 weeks and above, as shown in the diagrams, which you can look at it when you get the slides. So one of the other signs of pregnancy is quickening, which as I said is the first time a woman will perceive the movement of the baby, and this usually occurs at different times in both the multipara and the nullipara. In the primigravida, it usually occurs around 18 to 20 weeks, while in a woman that has given birth before, it usually occurs earlier at around 16 to 18 weeks of pregnancy. Then, as I said before, enlargement of the uterus is also one of the signs of pregnancy. So usually for antenatal care, you have usually the initial visit. For any model of the antenatal care you have the initial visit and then the follow-up visit. So for the traditional type of antenatal, the initial visit is usually the visit where a lot of things need to be done, which is what is actually practiced in Nigeria. At that initial visit, there is a medical history that is taken, physical examination is done, investigations are usually requested for, and then treatment of this patient as well as advice for optimal outcome in the pregnancy. So some of the medical history will just sometimes follows our normal medical history, but usually because this is done already by the nurses, you may not have to go through some of this again. Usually the biodata is of importance because it can help, especially in patients like Jehovah's Witness patients who probably has a previous scar and will not receive blood. It's always good to know that ahead of time, and especially if she has problems with her PCV, so that we can tackle it aggressively. And then the medical and family history of this patient is usually very important. Current prior or current health illnesses, health issues that this patient may have, things like hypertension, diabetes, even thyroid diseases, is very important to note in this patient. And then if this patient has allergy to medications, for instance, some patient would have allergies to sulfonamides or sulfur-containing drugs, And in those patients, it will be almost impossible to give them the intermittent prophylactic treatment in pregnancy. So a different, an alternative is usually given to them. And then, to know if they have possible inherited conditions in this patient and significant health issues in family members, especially things like tuberculosis, because pregnancy is the immunodepressive state. You want to know so that probably these patients can be well managed and to prevent them from getting some of these conditions from the family. And then whether this patient use alcohol, tobacco, or recreational drugs, these are risk factors for some of the conditions in pregnancy, as well as being teratogens that can affect, pregnancy, the pregnancy outcome as well.
Yeah,
So one of the important things usually in this period is the menstrual history, because the menstrual history is going to allow us to reliably date this pregnancy. And to reliably date this pregnancy, it's good to have a hello. 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 Hello.
Okay, try now.
Hello.
Sorry, you can continue. Sorry.
Okay. Okay, so I said one of the things that the menstrual history is going to help us to establish is going to be the date of the pregnancy, which is one of the very important things. Usually, for a patient that has had a regular menstrual cycle of 28 days, Naegele's rule is used, and Naegele's rule just states that for a woman that has had regular menstrual cycles of at least 28 days in the preceding 3 cycles, that the pregnancy would last an approximate 40 weeks or 280 days from her last menstrual period. So for Naegele's rule, when you want to calculate the gestational date of the pregnancy, you add 7 to the day, add either 3 or subtract 9 from the month, and then you may or may not add 1 year to the year column. So, as I said, add 7 to the days, and then add plus 3, add plus 9 or subtract 3 from the months, and then add plus or minus plus. You can add plus 1 or add nothing to the year. So, for instance, let's say for a woman that had an LMP, a last menstrual period of 7th of, let's say, April 2023, meaning that her expected delivery date would be 14. That's you add 7 to the 7, which makes it 14. And then because the month is just 4, you want to subtract 3 from the month, which will make it January, and then add 1 year, which will make it that will be 14th of January 2023. That's one of the easiest way, to calculate a woman's gestational age. Other things that can help us to date a pregnancy include the fetal heart tones. Usually, if we are using a Doppler or Sonicade, it will be easy to pick the fetal heart rate at 10 to 12 weeks with a Sonicade. However, from 20 weeks, we might also be able to pick it with a fetoscope. So those would also help us to know that this pregnancy is at so age, because by the time you start picking it with any of those instruments, then you're likely certain that this pregnancy is around that period. And then an ultrasound dating in the first trimester or the mid-second trimester is usually the most important dating method. Ultrasound in the first trimester has an error margin of around 5 days, 5 to 7 days, while in the second trimester, the error margin can be up to 10 to 14, while in the third trimester, the error margin can approximate about 21 days, which is about 3 weeks. How we used to know them is that you just Say 1 in the first trimester, which is 1 week, 2 in the second trimester, which is 2 weeks, and 3 in the third trimester, which is 3 weeks. So using an ultrasound, it can also be very easy to date a pregnancy. Another important thing to establish at that first visit is the parity of this woman and the gravidity. So gravidity is the number of pregnancies that a woman has had previously, irrespective of the outcome or the duration of the pregnancy. So for gravidity, every pregnancy counts. But parity is only pregnancies that reached the age of viability, which in Nigeria is 28 weeks. So if a pregnancy has not reached the age of viability, it cannot be counted in parity. And usually the current pregnancy is usually not included in parity because the woman has not yet delivered. So there's a 5-digit system that is used. The first is the gravidity, which is the total number of pregnancies. The second is the parity, which is the full-term pregnancies that reached 28 weeks. And then including preterm deliveries are also included there, especially those ones that were above the 28 weeks. And then there's usually a plus that is added on the top, which also captures the abortion, miscarriages, or the ectopic pregnancies in that pregnancies. And then the living children is also captured. Usually for most people, they put it in a bracket just after the parity. So following the history is taken, don't forget that the history of the current pregnancy is also taken to know whether this woman has bled, whether she has had any other problems in this index pregnancy. And then a physical examination is done for this patient. This includes a general examination, a routine blood pressure is taken. Hypertension in pregnancy is usually defined when the blood pressure is greater than 140, or diastolic of systolic, or diastolic is greater than 90, or there's an incremental rise of 30 systolic or 15 diastolic following after you follow this one for some time. And then the abdominal examination is done. Other parts of the general examination include, checking this woman's thyroid, checking the breasts to be sure that there is no issues. And then the abdominal examination usually follows, first and foremost, the first thing that is to be ascertained is to measure the fundal height or the secretofundal height. And then the presentation light, descent, and fetal heart tones are checked. The presentation light and the descent of the fetus is checked using the Leopold's Maneuver. The Leopold Maneuver has about 4 maneuvers. The first maneuver is where the fetal head is checked. The contents of the uterine fundus is checked. And then Leopold 2 is where the back and the side of the baby is checked for. And then Leopold 3 is where the content of the lower uterine segment is checked. And then for Leopold 4 is where the Polly's grab or descent is usually checked in this patient. I think we might need to probably project a video where these examinations are done so that you get just how this is done, because occasionally I've seen this in your examinations occasionally. And then the laboratory investigations that are done for these patients include routine tests, and then other ones that, when indicated, they are also done. For instance, for the routine test, a blood group and rhesus status is checked for, and then the full blood count, which the packed cell volume is what is more interesting to us. And then this patient is checked for HIV, and then hepatitis B, and then syphilis is also checked for, and then sickle cell. Then a dating ultrasound, as I've mentioned earlier. Urinalysis is done for protein and glucose in the urine, which is subsequently repeated in other visits. And then, if indicated, a strep test can be done, streptococcus test can be done, oral glucose tolerance test can be done, indirect cum test can be done, pap smear, as well as midstream urine for MCS. All these are when indicated for, they are also done. Hepatitis C screening is neither here nor there, although for patients who have some history, it might be requested, especially patients um, that have history of using of hard drug use where injections are given, or sharing of needles, tattoos or piercing, patients that have been in prison, okay, or patients that have tested or taken heart transfusion of blood tested positive for hepatitis C, or in those days they say people that were transfused before the year 1992. So the treatment for these patients at that first antenatal visit usually includes routine drugs like folic acid and elemental iron supplementation, and then intermittent preventive therapy for malaria, following quickening, and then prophylaxis for some conditions like low dose aspirin in patients who have hypertension, and then treatment of medical conditions like diabetes mellitus, in which patient can be treated either with metformin or with insulin, as well as patients that have thyroid diseases can also be treated in pregnancy, as well as other diseases as well. Then for immunization of these patients, there are certain immunizations that cannot be given to this patient. The live attenuated viruses are usually contraindicated in pregnancy, and these include measles, rubella, mumps, poliomyelitis. For inactive virus or vaccines, those can be given, influenza, the rabies, and then inactivated bacterial vaccines can also be given, like cholera, meningococcus, and typhoid. Tetanus toxoid can also be given in pregnancy. It's an inactivated bacteria, inactivated organism. And then immune globulins for hepatitis, tetanus, and rabies can also be given to these patients. I'm just showing a table here which shows the period where each of the doses of tetanus can be given and their protection level as well as their immunity. You can look at that in your spare time. And then these patients are usually counseled and advised. So counseling could include traveling, coitus. You know, there's no real problem with traveling for this patient. And then coitus, they are, usually coitus is not for, it's safe, but not preferred in the first trimester and the last 6 weeks of the pregnancy. And then bathing should be no restrictions, except the patient should be very careful so that they don't slip off and fall during bathing. And then douching, which is not really encouraged but should be done with only water with no soap. And then clothing should be non-restricting clothing. In fact, it's preferably to wear loose-fitting gowns. And then no care of the teeth is actually contraindicated in pregnancies. The breasts, well-fitting supporting braziers can be worn to prevent engorgement until maybe after delivery. Then those can be removed. And then bowel habits usually can become irregular. Some patients can have constipation. Some can have diarrhea, but usually these patients, can advise them on fruits and roughages, to make them, go to toilet normally, but there is no restriction per se. So some of the warning signs of which a patient is advised to visit the hospital back is bleeding, swelling of the face, fingers and limbs, swollen tender calves, severe headaches, blurring of vision, and then abdominal pain, persistent vomiting, chills and fever, escape of fluid from the vagina, and so on. All these are warning signs that a patient should immediately return to the hospital. So all these are usually done at the first visit. And then in addition to that, at that first visit also, the pregnancy usually is divided into those pregnancies that are high risk and those pregnancies that are low risk. Pregnancies that are high risk may be followed, more closely than the normal schedule, which is what is shown in the slide, which is being displayed now. So for patients that are high risk, include patients that are coming for delivery following a cesarean section, patients that have had different patients that have had surgeries like myomectomy before, patients with medical conditions like hypertension, diabetes, patients with sickle cell, and even patients which have had childhood diseases that are capable of causing contractile pelvis and any other thing except and even including patients in their first pregnancies. All these are classed as high risk pregnancy, which should be followed in a tertiary center and by a more skilled personnel. Patients that are in their second to fourth pregnancies without a previous scar or without any medical conditions can be managed even at the primary healthcare center. So the schedule for the traditional antenatal includes 4 weeks, 4 weekly until 28 weeks, 2 weekly until 36 weeks, and then weekly from 36 until delivery. So as I said before, patients with high risk usually do not follow this traditional visit schedule. So perinatal outcomes benefits were more pronounced with women who continue their care, antenatal care, even after 30 weeks. So usually these patients are advised to have the phone number of their care provider, which is not really usually feasible in Nigeria here. And then if a woman has had at least 4 antenatal visits in each of the trimester, the WHO usually considers that this woman has had a full antenatal care. So the following few slides just tries to, maybe you can read it when you on your free time. Just tries to, put together what I've already said, what is expected at the first visit, all the things that needs to be done at the first visit, and then depending on when that first visit is, what can be done. All these are captured in the next few slides, and as you have. And then there are other types of antenatal care models. There is the focused antenatal care, in which the quantity of the visits are not as stressed as the quality of the visit. In the focused antenatal care, 4 visits are done. The first visit is advised to be from around the 13 to around the 18 weeks. And then the second visit from 24 to about 38. And then the third visit from about 32 weeks to about 30.
Hello, Shivubong, are you there? Hello, are we there? Are we listening?
Yes,
So, okay, it's like he went off, Abby, or he's done.
probably his network went off.
Okay, so let's hold on for him for some minutes first now.